Dear brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to a new episode of Health from Huda TV. In the previous episode, we've talked about what diabetes does to the eye as a whole, and we've mentioned in one of the complications or the problems that diabetes does to the eye are the effects of the diabetes on the retina. The retina is the screen that perceives the light, and it's the most sensitive part of the eye, and it's very crucial when the diabetes comes to affect the retina and causes problems to the retina. With us today is Dr. Tamer Fahmy, consultant of ophthalmology at Ain Shams University in Cairo, Egypt, and he'll be talking to us about the details about what does the diabetes does to the retina. Dr. Tamer, thank you very much for coming today, and thank you for giving you so much information about something that I believe many of our viewers should be aware of.
Thank you very much for your invitation for this
program.
For
Yes.
this subject.
Yes. Diabetes is a problem on its own, but when it comes to doing complications to the body organs, especially the eye, which is one of the most precious parts of the body, of course, it's a catastrophe sometimes.
Yes.
Yes.
It's catastrophic, especially if we look to the statistic analysis about the diabetes, the change in the retina. We found that 40% of the patients have diabetic retinopathy, and as regards United States and England, the leading cause of the blindness among the adults is diabetic retinopathy.
That's a very big and a scary number.
Yes. But the blindness in United States or Europe is different from the blindness here.
Yes.
We consider the blindness there when the vision is dropped to below 660.
Yes.
That means the patient cannot work.
Uh-huh.
So that's why we consider there is the blindness.
Yes, exactly. So we talked previously about the problems that the diabetes causes to the eye, and we've just mentioned the retina as one of those problems. But I want you to tell us more about what is the retina and what does it do to the eye.
Okay, the retina is the most sensitive, as you mentioned before, the most sensitive and the most very critical part on the eye.
Yes.
If you see this movie, the retina is responsible for the vision. So if you see, you can see subject. This subject produce some impulses, can go inside the eye. When go, she will be focused by the certain structure on the eye, like the cornea, which is present in the front, and also focused more by the lens, which is responsible to make the image more sharp to fall down on the retina. When the impulses reach the retina, this initiates what is called the nerve impulses, which will pass through the retina.
Yes,
as we
this
see
is the
here in
close-up,
the
yes.
different layers of the retina. It's about 10 layers.
Yes.
It's very important structures, and with start to be go through the nerve fibers, will be go to the optic nerve until reach to the brain and perceived as the image.
Yes.
So it is very important structures, and it's very critical, and once what's happened is some damage inside these structures, we lose the vision.
Yes. So does that mean that you said 40% would just go with complications in the retina because of the diabetes? Does that
Yes.
mean that not everybody with diabetes would go through the problem of retinal problems, or how does it go?
It's a matter of time. It depends on the duration of diabetes, for how long the patient have diabetes.
Yes.
The statistics call that if the patient have diabetes for about 10 years, the incidence will be about 40%. If you can imagine that we have 10 patients, and the 10 patients have diabetes for 10 years, 4 of them will have diabetic retinopathy, or we have a change on diabetes on the retina, but the 6 will be free. If these 10 patients progress and stay with diabetes for about 15 years, the incidence will increase about 70%. 7 will have a diabetes, and if the diabetes is persist for this patient for about 20 years, about 90%. That means 9 of 10 person of these patients who have diabetes will have diabetic retinopathy. So it's a critical. It's a matter of time.
It's very scary, but
Yes.
does that mean that eventually the person would have a problem of a risk of blindness?
No, No, because
Yes.
the diabetes has a different stages.
Because we don't want to scare our viewers, because there is a difference between developing retinal problems
Yes.
and developing a very late stage of blindness.
Yes, yes, we have a different stage of diabetes.
Yes.
It's ranging between mild, moderate, severe changes,
Uh-huh.
and this change will be asymptomatic and doesn't affect the vision. And the
Yes.
patient, we can live in peace and doesn't matter with him. But the problem when we go to the stage 4, which is the proliferative change, and the advanced stage. In this stage, the patient starts to complain.
So can you take us into more details or deeper details about what changes happen to the retina with the diabetes, starting from the mild up to the very late
Is a
stages?
matter is a just what change is a change in the blood vessels,
Mhm.
which means that if the blood vessels have two main complications will happen.
Mhm.
Either leak of the fluid or blood or lipid,
Yes.
or occluded, and it produces ischemia,
Gets closed.
just closed.
Uh-huh.
Once you have a leak, this leak it may be present in a different part of the retina because the retina is a large size.
Mhm.
But the problem which occur in a certain critical point which is called the macula, which is the very important structure. Let me show you this video.
Yes.
It's about how can happen the macular edema occur.
Sure.
This is the macula and this is the retina. This is the blood vessels where the leakage occur. The leakage is the leakage of the fluid, and the retina will be edematous, and the leakage of the blood and will affect the vision. Another type, when the blood vessel is occluded or closed, there is a shrinkage in the retina as a size, and this means is impaired the function.
Because the blood is not going or flowing to that area, so it dies.
It will dies.
Mhm.
This is the main, or this is the early stages. But in the later stage, they're different because there is a new vessels formation, which will harm the retina and will harm the different structures under the eye.
Yes. So, when you said that these are usually asymptomatic, or the patient does not take any notice of it.
Yes.
So, when it comes to a further problem, what are the further problems that really do make the patient take care that he does have a problem with the eyes?
Usually the patient doesn't complain
Yes.
unless he go to the ophthalmologist doctor or eye doctors
Uh-huh.
for just change the refraction, change the glasses, or sometimes he's referred from the endocrinologist
Mhm.
about to see what about the fundus change.
Mhm.
And the patient unnoticed what's happened in his eye and what happened in his vision.
Mhm.
And when he tested him, we found he cannot see very well, and even he saw something is distorted,
Mhm.
like this. If the patient see this, he will see it's very clear. But look at this patient, who will see something is distorted.
Okay, I want you to take us back to the normal picture.
This is the normal picture.
Yes, and change it to the abnormal one.
Yeah, this is the distorted. Is
Uh-huh.
some part of the image is distorted.
Yeah.
And this is due to the swelling on the retina in certain critical part, which is the macula,
Mhm.
and he starts to complain.
Yes.
But later on, the patient may have another complaint like this. He have some dots, black dots inside his vision. He's
Mhm.
what's called is masca. He's like a black dots or shadows. He cannot see very well the structures. He cannot see very well the objects.
Yes.
And this is due to the hemorrhage what's happened inside the eye.
But there are some people who would complain of something black going into the
Inside
the
and it's
field.
moving.
Yes, and moving.
That's what we mentioned. That this is the
That's it.
hemorrhage.
Yes, it has to be
hemorrhage.
like that.
Yes, but this is the small degree of the hemorrhage.
Mhm.
But sometimes, if extensive hemorrhage, is block the vision, and the patient loses his vision,
Yes.
and we have to interfere and do the surgery for something like this.
Yes. So the worst case scenario is getting bleeding in there.
It's not the worst one because we have more worse than this.
What is that?
Let me show you the movie.
Yes.
If this is the eye, and we go inside this eye, and the blood vessel occluded, there is certain ischemic patches will happen in the retina, and these ischemic patches will induce some new vessels.
Yes.
These new vessels is very weak vessels, which may bleed and induce hemorrhage inside the eye, and sometimes this hemorrhage will attract on the retina and it induces what is called retinal detachment. And this detachment will also affect the vision and lose the vision. But at the end stage, this blood vessel will completely occlude even the arteries. And the patient, even we do anything for him, he will lose the vision and we cannot help him at all.
Yeah.
This is the most worst one. This is the end stage, or at the end stage of diabetic retinopathy.
Yes, that's quite scary. We have a short break, after which we'll be coming back to tell our viewers how to avoid getting into such a very bad complication. Brothers and sisters, we have a short break. Please don't go away until we're back. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear brothers, assalamu alaikum, and we're back and we're still talking about the diabetes mellitus and what does it do to your retina. Dr. Tamer Fahmy, consultant of ophthalmology, has been telling us about the wide spectrum of the effects of diabetes on the retina. Dr. Tamer, we stopped at the worst case scenario, which is the retinal detachment, and of course, I hope nobody gets it.
Yes.
But let's start from the beginning when the patient comes to you in the clinic. And either he knows or she knows that they have diabetes or they do not. So what do you do first for the examination or investigating the problem if you suspect that there's a problem with the retina?
The first things we have to do is just examination of the eye. It's
Yes.
complete examination, including the visions and the visual acuity, which is the critical part.
Yes.
Fundus examination, and we have to dilate the patient very well to see the periphery of the retina, and we see if it start to have a complication or not. But once we have a complication like the macular edema or have a new vessels formation, we have to ask for certain investigations,
Yes.
which including what's called fluorescein angiography. We have photographed the fundus or photographed the retina by certain dye injected intravenous,
Yes.
and we saw the blood vessels. Is it leaky or not leaky? It's very important for us to treat these cases or not.
Yes.
And also we do what's called the OCT, the optical coherence tomography. It's a new non-invasive investigations, give further details about the thickness of the macula, about the edema, the site and the size, there is any fibrous tissue formation over the surface of the macula, because each one of these investigation, either fluorescein angiography or the OCT, affect the modalities of the treatment.
Yes, of course. So take us to the modalities of the treatment, as you call it. I mean, when you discovered that there's the early changes that the patient usually doesn't know that they have,
Yes.
they have it. What do you do for the retina to prevent the further deterioration of the problem or deterioration of the retina itself?
We have to say something, or we have to mention or to remind the patient about something.
Yes.
The diabetes or diabetic retinopathy is a part of the major problem is diabetes.
Exactly.
So it is not my work alone, it's a teamwork. It is including the patient. We have to refer it again back to the internist or even to the endocrinologist
Yes.
to treat diabetes and to control diabetes, because the risk factor for progressing of the disease, not for the incidence of the disease, for progressing, to pass from stage 1 to stage 2 to stage 3, or
Yeah.
even to reach proliferative change, or to have a new vessel or traction attachment, mainly depend on the control of diabetes.
Yes.
And other factors like the hypertension or the smoking or anemia or pregnancy or renal problem. So this is not my work. It's
Yes.
mainly for the internist to work about that and to treat or to control this and other factors.
So number one,
Refer-
manage your diabetes. Do not be reluctant to treat it.
Yeah, and very well controlled.
Very well controlled.
Because the second most important thing,
Yes.
even if I treat the patient, I have to ask the patient to control diabetes, because
Exactly.
what I treat may recur back
Yes,
if he's not controlled.
of course.
So the work is depend on me and depend on the endocrinologist. So we have to work together.
Okay, so as an ophthalmologist, for the early stages, do you just suggest that you they
Follow
would
up.
follow up? Just
Except
only
if have
follow
two
up.
main complications:
What are they?
new vessel formation or diabetic macular edema.
Why do new vessels form on the retina?
Why new vessel formed?
Yes.
It's formed because this is ischemia. This blood vessel is occluded. and there is a certain substance will induce or even it released from the retina, from the ischemic retina, to initiate what is called a new vessels. But the new vessels is formed, the new vessels is very weak vessels, cannot withstand the normal blood pressure. So just by mild straining or even slight increase for blood pressure, it will be ruptured and will induce hemorrhage.
Yes.
And this hemorrhage later on will be contract, and this contract on the retina and will induce traction retinal detachment.
Yes.
That's why the new vessel is very critical. We have to treat early, as soon as possible, before it's induce further complications.
So when we have a considerable amount of new vessel formation, does that reflect on the symptoms of the patient, like there's deterioration of the vision or
New vessel itself not affect the vision unless it's induced some hemorrhage.
hemorrhage?
Once happen hemorrhage, as we see in this picture,
Yes.
we found just some shadows inside the image. He cannot see very well. Something obstructed his vision. That's what he start to complain. Otherwise, if the new vessels alone without any hemorrhage, he doesn't complain at all.
Okay. So if you discover the new vessels either with hemorrhage or before hemorrhage happens, what do?
Once we have a new vessels, we have to treat by the laser.
Laser.
Yes.
Yes.
The laser is the energy which induce some reaction inside the eye. This reaction will change the retina from what is called ischemic to what is called anoxic, which not need the oxygen, and they stop release of this substance which induce the new vessels.
Yes.
And can you see that in this movie?
So laser is for the new vessels.
Yes, yes. This was called the scatter photocoagulation. We treat the whole the retina by the laser. Just we apply the lens and we do the external laser to the periphery of the retina. Later on, all the retina will be covered by the laser like this, except the macular area is spared to see very well, and the new vessel spontaneously will regress and completely recovered and completely returned back to the normal.
But you cannot do the laser on the vessels that would form on the macula. Can you do that?
The macula is avascular. That's new node vessels will be formed on the macula. But
That's good.
what we do the laser on the macula for the macular edema.
Yes.
As we say, the macular edema is a leaking. That's we have a leaking point in the vessels. So this leaking point is just occluded by the
laser
lasers.
as well.
Yeah, like this. If you see this movie, this is the retina, and we focus on the macula, and this is the blood vessel which is dilated and leaking blood vessels.
Yes.
No, sorry.
Okay, so if the bleeding do occur inside the eye,
Yes.
that's another thing, because this could be an emergency, as I believe. The patient will be starting to lose the vision, or the vision will decrease, so he'll be running or she'll be running to the hospital or the doctor asking for an urgent treatment.
Yes.
So what do you do when this happens?
Once this happens, we have to ask for something called B scan or ultrasound to the eye to evaluate something. Is it just only vitreous hemorrhage, or we have also retinal detachment by this vitreous hemorrhage? And immediately we can give him the patients some is called antifibrotic material to help to absorption of this blood. About 50% of the cases may respond to the medical treatment, but if they have just only vitreous hemorrhage. But once we have extensive vitreous hemorrhage or even retinal detachment, we have to interfere by do what's called vitrectomy.
Yes, vitrectomy. Let's define the word vitreous first, because I'm not sure most of our viewers will know what vitreous is.
Okay, the eye is not this form is just only the certain structures, about 3 layers.
Yes.
But the content or the main bulk of the eye is like a bowl.
Yes.
This is a filled with the fluid. This is a fluid what is called aqueous, and some is called is the vitreous. And this vitreous is a like gel-like material,
Yes.
just only fill the cavity inside the eye.
And very transparent, of course.
Yes, of course.
Yeah.
This is a trans. It have no function.
Just a filling material.
Just only the filling material. What with the new vessels or even the vitreous image fill this the cavity and fill this the gel-like material. So we have to introduce inside the eye to absorb this hemorrhage inside and absorb this vitreous also, and we clean this cavity. No.
Yes.
We clean this cavity. And then after the end of the surgery, we do just laser like we did just as we showed before.
Yes. So, but does that apply? You just inject something else to replace this?
We just inject saline, and already the eye have a continuous production of the aqueous, which is the fluid special for the eye.
Yes.
And this will be absorbed with the saline which was which injected during the operation and replaces by the normal aqueous production.
Yes. So this leaves us with the last but the most serious complication, as you said before, the retinal detachment.
Yes.
If we do have retinal detachment, how do you manage?
The same management. But it depends. Yeah, it's the same management. We need also vitrectomy, but at the same time, this patient, this retina is detached from the original site. We have to return back or to get back to the normal position, and to fix by normal position by laser and inject a certain material to maintain this position, which is called the silicone. Silicone oil is a certain material heavier than the liquid, or even heavier than fluid like the aqueous, and can support the retina in this position until the laser work about 2 months or 3 months later, and you can remove the silicone and everything return back to the normal.
That's great. So
But the problem, if this retinal detachment associated with closed blood vessels, we cannot do anything for the patient because it's extensive ischemic retina.
There's no nourishment going in there,
and we cannot open the vessels anymore.
Yeah. Yeah. So this is really serious, and I hope our viewers just take care of themselves and won't let themselves go into this bad situation.
Yes, I
for
hope
them
that,
and the doctor.
and I hope they do all the regular follow-up.
Yes. Yes, that's very important, Dr. Tamer Fahmy. Thank you very much for coming today, and thank you for all the information that you provided us today. I'm sure most of our viewers really wanted to know about this thing, and I'm sure they benefited today. Brothers and sisters, thank you very much for being with us today. I hope that all of you would take care of yourself, do a follow-up, especially those who would have diabetes, and don't miss the opportunity of not getting into such a bad problem. Please write to us on our email. It's health@huda.tv, and our Facebook is facebook.com/health.huda.tv, and of course our website is huda.tv. Until next episode, I hope that all of you would have a happy and healthy life. Until then, assalamu alaikum wa rahmatullahi wa barakatuh.